Good afternoon and welcome to the May provider call. We have folks still coming in, so I'm just going to give folks a couple of minutes. We'll keep admitting people and we'll get started. We have a pretty packed agenda, so just hang tight for about a minute and we'll get started. All right, gang. I don't want to hold folks up, and I know we'll have people coming in. We've got quite a bit to cover today, so I'm just going to start with a couple of pieces of legislation that have some implications for early
And
childhood.
so I just wanted,
Oop, hang on, make sure we get all the sound right. All right. Um, there are there. Sorry about that. There were three pieces that I think have probably more specific impact on early childhood. So I'm just going to run through these quickly. We have some other guests that are going to be talking today, so I want to make sure they have plenty of time. Act 504 streamlines eligibility in ABC from two sets of criteria to one. So, for those of you who administer the Arkansas Better Chance program, you're probably aware that there was funding that was part of the original law that created ABC back in the 90s. A lot of people refer to it as old ABC money. And then there was funding when they did the expansion in early 2000 and added the 100 million, and it had a different set of criteria. So Act 504 just allows for all of that to be streamlined and that all Arkansas Better Chance programs can serve children birth to 5. So if you were in a rural community and this year you were serving preschool, but next year you were saying, well, I only have, 10 preschoolers, but I could do some infants and toddlers, you would have the ability to serve infants and toddlers. We will also be revising the rules and regulations to support this law, but theoretically, the rules that are attached to the original ABC funding, that list of criteria, that children would have to meet one of those. So if you're not sure, those of you who are doing Arkansas Better Chance, look at the current rules, and the rules for ABC, Arkansas Better Chance, not ABCSS, are likely the rules that will be presenting as rules for the ABC program. We may add something about active military or military deployment to that list, but I don't think anything else will change. Might be some word cleanup, but that's what Act 504 does. Um, Act 1817 did not have a number assigned to it. I know that it does now. But it did pass. So someone can pop that into the chat box and let folks know what that number is, so everyone can see it. But it requires us to work with the Department of Health to create a statewide anaphylaxis plan for childcare facilities. Many of you know that you already have an emergency care plan. It's part of the licensing regulations and will continue to be. We're just adding that anaphylaxis plan into that part of the licensing rules. I don't think it's going to significantly change anything, but we'll just have that word specifically um, in the licensing rules with the emergency care plans. Um, And then Act 587 is a new one that will allow early childhood professionals that are in non-public school programs to participate in Arkansas teacher retirement. So let's just say you're an existing private early childhood program and you purchase teacher retirement benefits for your employees. You could shift that retirement plan to the Arkansas Teacher Retirement Plan. The Arkansas Teacher Retirement Agency is currently starting to work on rules and regs for that. So there isn't anything in place yet, but just know that that is something that, will likely be available in the next year. So I'm going to stop there. I'll continue to check for questions. I know that Jennifer has put in the act number for Elijah's Law in the chat box, so you can look at that. But we have an important guest, and Catherine or Kat Waters reached out to me last week about, and I know many of you have heard from a few of you about measles outbreak in the state and what's happening in the country. So we've always worked very closely with the Department of Health, and we certainly do whenever there are communicable diseases. And she's going to talk to us a little bit about that, and they have a lot of resources at the Department of Health, which we've started sharing out. But I wanted to make sure they had plenty of time to talk and answer questions if you have any about maybe what to do or how to handle what's happening around measles. So, Kat, if you want to get started.
Okay, thank you so much. And I know it has me being the main presenter, but actually Dr. Cassandra Lotredo is actually going to do the presentation part, and we kind of talked about what we wanted to present, and I'll jump in and answer questions and help where I can, but I wanted to kind of let her start with an overview. And she's already shared some documents in the sidebar, but for those of you that don't know me, I'm Kat Waters. I'm the Outbreak Prevention and Response Branch Chief here at the Arkansas Department of Health. And then Dr. Cassandra Lotredo is our medical director. So I'll just share the screen and let her get started.
Hey, you guys. Which screen are you seeing?
Your measles.
Okay, is it presenter view or?
Yes. Yes.
Measles tracker focus.
Okay, perfect. So just a regular screen. You guys can't see my notes, can you?
Cool. No, we cannot see your notes.
Okay. Hey, you guys. My name's Cassandra Lotredo. I'm the medical director of the Outbreak Prevention and Response Branch here at the Arkansas Department of Health. I get the wonderful pleasure of working with Kat and the rest of the team basically every day. Love them. I'm just going to talk to you guys a little bit about measles today. So disclosures, I don't have any financial disclosures, and any opinions or views expressed are my own and don't necessarily reflect that of my employer. Just a couple of objectives, taking a look at the current situation regarding measles in the United States. And then I am a clinician, I am a physician, infectious diseases by training. So I will talk a little bit about the clinical features associated with the measles presentation, and then talk a little bit about what it would look like if there was an exposure in a childcare setting, and kind of what the interaction would be with the Department of Health. So just a 5,000 foot view. Measles is a virus that causes a respiratory viral illness that is transmitted human to human via large respiratory droplets. So when someone coughs or sneezes, however, it can hang out in the air in closed areas for up to 2 hours, usually happening in the late winter and spring. And the infectious period, or the time at which this virus can be transmitted from one person to another person, is 4 days before rash onset through 4 days after rash onset, with that rash onset day being day 0. For people with weak immune systems who are immunocompromised, that transmission time varies a little bit. It is really considered the duration of the illness, because sometimes these individuals maybe don't have a rash. Taking a look at this figure right here, the reason why we care so much about measles is because it's a highly contagious infection. And as I said, spreads through the air when an infected person coughs or sneezes. So it's so contagious that if like one person with measles walks into a room and there are 10 people in that room that are not protected against measles, so maybe they're, not at the appropriate age that they've been able to receive their MMR vaccine. And so no doses of MMR vaccine for all 10 of those people. 9 of those people will also become infected with measles. And so that's why we highlight this so much. This is a graph that basically takes a look at the reported measles cases in the United States from 1962 to 2023. You can see that before the vaccine was licensed in 1963, there were about 500,000 reported cases and about 500 deaths reported annually before the vaccine. Of these reported cases, about 48,000 people were hospitalized from measles. 1,000 people developed kind of chronic disability from acute encephalitis or swelling of the brain every year because of measles. That's kind of the reported number of cases. The actual cases were estimated to be around 3 to 4 million, because remember, the diagnostic testing capabilities in the 1960s are different than they are now. After the vaccine was licensed in 1963, the incidence or the number of new cases dropped by over 95%, which is absolutely fantastic. And you can see it really got down very low here. In 1989, you can see that there was a slight bump, and this was a bump of measles cases that were occurring in vaccinated school-age children in the 1980s, and that led to the recommendation for a second dose of MMR vaccine. And so that's why kiddos between ages of 4 and 6 get that second dose. And since, you know, the 2000s, the annual number of cases has really ranged from a low of 37 to, which was in 2004, to a high of 1,282 in 2019. And you can see in 2000, measles elimination was declared in the United States. And that means that there was no transmission in the community of measles from one person to another in the United States. All of the measles cases were essentially, individuals that had traveled outside of the United States and then brought measles back with them. Things have changed a little bit. There has been an increase in the number of domestic or inside the United States measles cases since late January 2025, predominantly occurring in like the West Texas and New Mexico communities with lower immunization rates. And so this is just showing a weekly measles cases by rash onset date, going from January 2023 all the way through April 2025. And this is kind of currently where we've been at. All this information can be found on the CDC's website. Google CDC measles outbreak, and you'll be able to find all this info. This is kind of a little bit more of the case information. So the number of confirmed cases of measles in 2025 as of May 2nd is 935. As you can see, occurring, mainly in that pediatric patient population right here, predominantly occurring in individuals who are unvaccinated or have an unknown vaccination status. However, I will mention that, nothing is 100% effective in this world. And so, MMR vaccine, 1 dose is 93% effective at preventing measles in that person, and 2 doses are 97% effective in preventing measles. So there's still a very small percent chance that an individual, if vaccinated, can get measles. Luckily, these cases are usually much more mild and much less likely to kind of transmit infection onto others. But I just wanted to bring that up because you can see that there have been some cases in individuals that have had vaccination previously. But MMR vaccine is the best way to prevent, getting really sick and potentially, deaths due to measles. In the United States, hospitalizations in 2025, about 13% of the cases have been hospitalized, predominantly occurring in that really young kiddo age group, so the under 5 years old. And as you can see, there have been 3 confirmed deaths from measles in 2025. So 2 pediatric cases in the West Texas outbreak area, and then 1 adult case in a New Mexico resident. And as I said, all this information can be found on the CDC's website. This is a general geographic distribution of the measles cases in 2025. As you can see, the darker areas are is where we have more cases. So really occurring in, Texas, New Mexico. There's also an ongoing outbreak in Chihuahua, Mexico, and then up here in Canada as well. And as you can see, Arkansas is highlighted in a light blue, meaning that there's been 1 to 9 cases. So I'll just talk about that a little bit. So the first case of measles in Arkansas that was identified since 2018 was first reported on April 10th, essentially a pediatric individual who is unvaccinated in Saline County. As you can see here, there was multiple areas of exposure, multiple locations of exposure. Second case, also a pediatric individual who is unvaccinated. This individual lived in Faulkner County. Both of these individuals had traveled out of state. And these are the locations where that individual was infectious, and that's exposure locations. There was a fourth case most recently that was identified, and there was a press release on April 29th. That individual was not fully vaccinated, pediatric, residing in, because this individual really didn't have any reported travel outside of the state, and there was no clear link to any other case. We were concerned that this was evidence of community spread of measles in Arkansas this year, and that's why we updated the vaccine recommendations for anyone living in Faulkner County and the surrounding counties. Essentially, providing permissive information like, hey, your kiddo may get an MMR vaccine early, between 6 to 11 months old. That's a dose 0. And, your older kiddos that are greater than or equal to 1 year old up through adulthood can get their second dose early, as long as it is 28 days after that initial dose. Kind of why are we running into this situation here in the United States? And part of that is because there's a decline in community protection nationwide, including Arkansas. So when at least 95% of a community has immunity to measles, the individuals that are in the community that maybe are not able to be vaccinated because they're of a younger age, they have a weak immune system, or another reason, are protected just because measles can't spread, because most people are covered. However, in recent years, the estimated percent number of individuals that are vaccinated has declined to less than 95%. So MMR vaccine coverage for kindergartners for the 2023 to 2024 school year nationwide is at 92.7%, and here in Arkansas, it's 92.5%. And that's just general coverage for the state. It varies in regards to counties and different community levels. So that information, I think, can also be found maybe on the Department of Education's website for school district data for public schools, but I would recommend looking on that website. As I said earlier, 1 dose of MMR, 93% effective at preventing measles, 2 doses, 97% effective. But as I said, immunization coverage has fallen below the 95% needed to prevent transmission. And some, unvaccinated children can often be clustered in smaller communities, and that increased the risk of transmission at smaller local levels. And then I just wanted to highlight here that the Arkansas State Board of Health rules and regulations pertaining to immunization requirements, which was last updated in September of 2014, requires childhood vaccinations for entry into childcare and early childhood education facilities in public school. However, you can see that medical exemptions have always been allowed, but there has been an increase in the number of religious and philosophical exemptions since the early 2000s. So up to, 16,000 exemptions as of the 2024 to 2025 school year. The rules and regulations, as I said, pertaining to immunization requirements can be found here. You can Google this, and as I said, vaccination exemptions can include medical, religious, and philosophical exemptions. We really recommend that you are aware of the immunization status of every child in your facility. And then I just wanted to bring up these PDFs that talk about the minimum licensing requirements for child care family homes and child care centers put out from DHS, which includes information about, if someone is having a symptom of a communicable disease, including measles, that child, should not necessarily return to that child care setting until at least 4 days after the onset of the rash. And so that's kind of what I talked about earlier, a child being, or an individual being infectious and be able to transmit that infection to others 4 days before rash onset through 4 days after rash onset. And all of this can be found in the PDFs that I just showed.
Okay, can you repeat that?
Yes. So basically, I Googled and did some screenshotting. So these are the minimum licensing requirements for child care centers and licensed child care family homes. And I just took a screenshot of one of the pages in there. And part of that says that the child care, the caregiver shall temporarily exclude the child from child care if the child has. And this is just a list of what is included in those licensing recommendations. And then I just wanted to draw attention to R, which really focuses on measles, and that child should not necessarily come back to the child care facility until 4 days after the onset of rash. And, these are the, general recommendations that we provide to child care facilities and to schools. And, these are the recommendations, but ultimately it is up to that child care facility or that school to enforce, attendance policy. Does that answer your question? Any other questions about that? Cool. Water. Okay, so I'm a clinician, so I always tend to think about case-based scenarios. So for example, say you've got a 7-month-old kiddo that attends a daycare who returned from Montreal, Canada about 2 weeks ago, who's got a high fever up to 101 over the weekend, has got a runny nose, red watery eyes, maybe a little bit of a cough, followed by a rash that shows up midweek. It started on the hairline and then it spread all the way down to the neck, chest, arms, legs, and feet, maybe even the palms and the soles. Unfortunately, the child did not receive an MMR vaccine prior to international travel, which it is recommended between 6 to 11 months. If a kiddo is going out of the country for international travel, they should receive an MMR vaccine. And ultimately, the child is diagnosed with measles. So once again, highly contagious, can lead to serious complications. The first symptoms really appear after 7 to 14 days. That includes fever, cough, runny nose, those red watery eyes. That rash usually starts about 14 days after exposure, but can really range between 7 to 21 days. And as I've said like 20 times, an individual can spread measles to others from 4 days before the rash onset through 4 days after. A little bit more about the clinical features. So the incubation period is medical speak for exactly like when someone was exposed to someone with measles and they're not having any symptoms until they develop symptoms. So it's like that 11 to 12 days between exposure to development of symptoms. And as I said, usually it's the cough, the fever, the runny nose. Those are the initial symptoms, followed by that rash onset about 2 weeks later. That prodrome is what we call it. So that, that fever, that cough, that runny nose, those red watery eyes, and these things called Koplik spots, which are like little white dots in the back of the mouth, teeny tiny. It looks like grains of sand or speckles of sand on a reddish background. In the back of the mouth. Those are kind of the initial symptoms, and they last for about 2 to 4 days. And you can see a photo here of a little kiddo with measles that's got that runny nose and those watery eyes. Then the rash will develop. It lasts for about 5 to 6 days, and it starts on the hairline and involves the face and the upper neck, and then it moves downward and outward. And as I said, can include the palms and the soles. And severe areas can really peel off in scales, and then it fades in the same order of appearance. And at first it'll be like little dots kind of all places, and then they coalesce and kind of come together and become like a little bit darker. I really like this image because it kind of shows that you get, you know, the fever, the red watery eyes, kind of those gnarly, those cold symptoms, and a little bit of a cough before you start to see that rash. Sorry about the excessive clinicalness of this. I thought that it would be at least good to kind of go over all the symptoms and stuff. Once again, this is the photo of the kiddo with the watery eyes, runny nose. Same thing here. Runny nose, watery eyes. Also, kiddo has a raised rash, as you can see. These are like the teeny tiny coplet spots. I don't necessarily recommend that you go ahead and start looking in children's mouths about this stuff. It can be hard for clinicians even to detect these coplet spots. And, you know, I've seen some photos of aphthous ulcers, like the cold sores and, you know, stuff like that. So just for your information. And once again, this is another photo. This is the same photo of that measles rash. This is a photo of a child who had the severe rash, and then now there was the scaling and kind of like the peeling off of the skin in those kind of intense regions. This is the skin of a patient after 3 days of that measles rash. You can see that there's teeny tiny dots everywhere, but in some areas, those teeny tiny dots have all merged together. This is an image of a child with darker skin that has the measles rash, those darker areas, and they coalesce together. Another photo, picture's worth 1,000 words, of a fairer skinned child with the characteristic rash. I do want to say that something called modified measles, so that's basically measles, but measles not as intense, because that person that got measles had a little bit of extra protection, and that extra protection can be post-exposure prophylaxis, which is kind of preventive treatment that is given to someone after they've been exposed to measles, and can also occur in, you know, some young infants that still have a little bit of that maternal antibody after, you know, transfer during delivery. The clinical kind of picture is a little bit longer time to develop signs and symptoms, and it's a milder disease. And as I said before, individuals that have been previously vaccinated can kind of have a similar picture. Who's at risk for severe measles? Well, it can be serious in all age groups, but especially those kiddos that are less than 5 years old, adults older than 20 years, pregnant women, and people with weakened immune systems. To the point where there's some pretty severe complications of measles, including, you know, hospitalization, which can occur in 1 in 5 unvaccinated people in the United States, pneumonia in 1 out of every 20 children. That's because this virus just wreaks havoc on your immune system and makes your immune system forget everything that happened to it before, and puts you at higher risk for like bacterial infections in your lungs. So that's like the pneumonia aspect. Encephalitis, that's the brain swelling that can lead to long-term neurologic complications, deafness, things like that, sometimes intellectual disability, death in nearly 1 to 3 out of every 1,000 children, and there can be complications that occur during pregnancy. This just talks a little bit about that whole fact that sometimes your body forgets what happened before measles. So a lot of the deaths, as I said, related to measles are due to those secondary infections. And that's when the immune system forgets how to fight off those infections it successfully dealt with before, even those that they were previously vaccinated against or had already been exposed to. And this can last for years. There was a really good Harvard Magazine article about it, in addition to the scientific article. Big fan of the Harvard Magazine. So as I said, we've gone through the background of what's happening in the United States now, what's happened previously. We've gone through kind of what does measles actually look like. So now I wanted to go through a hypothetical case scenario and how you can prepare and respond to measles in your child care center. So these are screenshots from the PDF that I posted in the chat a little bit earlier. So basically, it gives a little bit of background and says, hey, measles can spread quickly. It's quite contagious. It can be severe for specific patient populations, and the MMR vaccine is safe and effective at preventing measles. So really how to prepare is to ensure that children are vaccinated with the MMR vaccine or have, a valid exemption on file, and know who those kiddos are. Encourage your staff to confirm that they've received the vaccine or have immunity to measles. And if they know that they aren't immune, encourage them to receive the MMR vaccine. Really make sure that you save these immunization and exemption records for all these children. Make sure that they're, current and easy to look up. And let families of unvaccinated children and unvaccinated staff know that they may need to stay home for up to 21 days each time that they're near someone with measles. And that's because, as I said before, 9 out of 10 people that are not protected against measles and that are exposed will develop measles. And that's why, that is the recommendation essentially. Be aware of the signs and symptoms of measles that we just all went through. And you can find on our website, there's a measles kind of fact sheet, and we've got a bunch of information on the website. And I dropped that into the chat initially. So what are the steps to take if there's been a person with measles at your center? Please let us know. Basically, this is our contact information for the Outbreak Prevention Response Branch or our outbreak nurses during normal business hours, or that you can give the Emergency Communications Center a call outside of those normal business hours. Please chat with us, follow the instructions that we give to you. You'll need to review the attendance records for the children that attended your center during the time the person with measles may have been at your center. So really making sure that you know the child or staff member's first and last name, address, phone number, parents' first and last names, date of birth, days the child normally attends your center, and the classroom of the child, and MMR vaccination date, if applicable. And so that's just to kind of get an idea of who was exposed and what are the next steps that we need to do for those kiddos and for staff members. Also making sure that, hey, once you've identified that there has been an exposure, keeping us informed and just that clear communication with us, like if anyone else becomes sick, and just kind of, keeping in touch with us and clear communication. And really, why do we need this information? I've, really tried to highlight that it can spread very easily and rapidly, can cause severe disease, especially in those little kiddos and those immunocompromised individuals or people with weak immune systems. And this just speaks to a little bit of the law for reporting communicable diseases. As I said, how does measles spread? Through contact with an infected person, so coughing or sneezing, and then contact with those air droplets. Because measles can live in the air for up to 2 hours after a person leaves that area. This is just a big pink box stating that same thing. So what does a potential facility exposure kind of look like? So I've got this image of a, potential childcare facility off the internet. So say you've got a kiddo that has measles, enters the daycare facility, enters the childcare facility, enters the hallway, goes into the young infant room, and then, makes the same way back out. So that means that if they entered at 8 o'clock in the morning and then they say maybe left at 9 o'clock in the morning for whatever reason, they're only there for an hour, there would be an exposure in all those areas for up to 2 hours after that person left. So if they left at 9, that means the exposure time is still till 11 o'clock in the morning. So 8 o'clock to 11 o'clock. That's a lot of people that are potentially exposed. This is a signage that we provide to healthcare facilities. I don't know if it's necessarily the best to put on your childcare facility's door, but this is just signage that helps healthcare facilities let their patients know, like, hey, if you have any of these symptoms, please give us a call before you enter, just to decrease the risk of exposure in the facility. So a general kind of thought process. So say, for example, on 4/17, a child goes to a specific location. What is an exposure? So sharing the same airspace as that child, or being present in that area for up to a maximum of 2 hours after that child with measles leaves. So as I said, say for example, they arrive at the location at 8 a.m. and they leave at 9 a.m. That estimated exposure time is 8 a.m. through 11 o'clock in the morning because of that maximum of 2 hours after that person leaves. Once again, if there is an exposure, for example, this is the information that we would be wanting to kind of obtain. So, okay, now that we know there has been an exposure, we know the time and the location of the exposure, let's get an idea of who was exposed. This is kind of the information that we would ask for. And once we obtain that information, we take a look at it. We see kind of what's their MMR vaccination status, what was the time of the exposure. And then the next steps we take are how can we, decrease the possibility that that exposed person, if they're not immune, is going to get measles. And that is a very confusing and very medical chart that I'm putting up here right now for you guys. But essentially, it's all about, if they are not immune and they're greater than a year old, so they've never had the vaccine, if it's within 72 hours or less than 3 days, we can give them an MMR vaccine to decrease the risk of getting measles or severe measles, and they can continue on their regular activities. However, if you've got, a less than 6-month-old that isn't immune because they've never gotten an MMR vaccine because it's not appropriate for them to get that, the best protection that we can give them is this thing called immune globulin intramuscular. So basically that's like a shot of antibodies into, their thigh that helps protect them against severe disease. And these kiddos, because they really have never had any protection before, and we're just giving them a little bit of extra protection, those individuals are recommended to stay home for up to 28 days. And so this is kind of what we look at from the health department standpoint after you guys provide us that line list of the exposed individuals. And all this information, if you're ever curious about it, can be found online. This is based off of the American Academy of Pediatrics Red Book, the chapter on measles. This is specifically for pregnant women and for immunocompromised individuals because that could apply to some of your staff members as well. That was a whirlwind. Please let me know if you have any questions, and I'm sure that you do. And
Dr. Locher, we have several questions in the chat, so I thought I would just kind of start running through some of those real quick.
Perfect.
Let me go back up and see. So the first thing someone had asked was if a child is being tested for measles and awaiting results, and they put 4 days in the parentheses. So I want to talk about that. Should we alert other parents before the confirmed results or after? Because we don't want to cause an alarm, and that's correct. So I had put in the chat or the comments that we don't recommend alerting anyone, like the parents, that there's a possible measles until we know there's a possible measles. But I want to clarify that we do want you to let us know here at the health department, because then we can start the investigation on our side and we can be talking with you to kind of know what steps you need to be doing, and we can try to coordinate where that sample is going or where it is at. Some samples we want to come directly here to the health department. If they're a very high suspicious case that we really think is measles, we want to get that test here, and we want to get that test result like in a day or 2, if we can. But if we talk to someone and it's really not on our suspicious level of measles, but the doctor wants to do that, they can send it to outside labs, but that may take 3 or 4 days. But if you're testing someone for measles, like a doctor, you would tell them, you need to stay home till we get the results. So there may be a child that says, I've been told to stay home, I'm being checked for measles. That's when you may want to give the health department or send an email to our nurses here and let us check into it just to see what's going on. But I would not advise sending out anything to other parents at that time. I mean, y'all can certainly do whatever is your policy, But I'm just going to tell you that when you do that, that causes a great sense of panic and alarm. And then everybody's saying they got measles and they don't. And it can cause a lot of craziness, which I'm sure y'all are aware of. And then I think someone asked if the slides were going to be put on the website, and I think that's been addressed. Then let's see. Let me just look
And
here.
yeah, can we ask employees if they are vaccinated? I mean, I would,
That we need to defer to.
yeah.
There's nothing in the rule, and that really, if you're a private entity or whatever first I would say, what's in your current policy? When you're hiring someone, that's the time to get answers to questions. But if there's an outbreak like is happening now, this would be a time to sit down with your team and share this information and let them know. I mean, they're really potentially at risk based on the information that we've heard today. So I think you're trying to make sure that your place is secured in some way or you're mitigating the risk. So I think it would be appropriate. Now, having said that, someone doesn't necessarily have to answer that question. They may not answer that question. So just know that going into it. But I think based on the conversation today, this is a time where you might want to make sure your employees are aware of something that's happening that could cause real harm, both to them and to children.
And we did put our email address for the ORS nurses there. I know it was in the slides as well, and our phone numbers. And then can you provide more details on exposure? COVID was 6 foot and for so many minutes. Okay, with measles, it's sharing airspace. And that can be a little tricky. So I know Dr. Lotrideau showed the little graph to where the child came in through the entrance, then went to their room. It may be that simple or it may not be. That's why we have to get involved and really look at the layout, and we have to look at the air system. And sometimes it may be that if someone comes into a daycare facility that they've exposed the whole facility. So that is why it's so important now, before you ever get a case, to start doing those preparations of what does my facility policy say? Can I, do I have immunization records on all my kids? Do I have that verified? Do I know kind of who would be at risk, who's not? Am I having those conversations now to kind of just make sure people are fully aware? Because, it could be that someone walks into the daycare, but they go from one room in the morning to where they break out and go to a classroom. And then in the afternoons, they all gather together before pickup time. And I noticed someone mentioned a comment about keeping all the kids in their classroom. And we're not saying that you have to keep kids in classrooms at all. You need to do whatever your policy is for your facility. I would not limit the kids' movements based on what just discussing measles. If you have a child that you think has measles, they don't need to be at daycare, but that's up to your facility to enforce that. But as far as separating kids right now, trying to keep them in one location, that's not what we're saying at all. And then someone said that if we put out there that there will be out for 21 days if exposed and not vaccinated, parents won't tell us if they've been exposed. You're correct. Sometimes there is that risk that they're not going to tell you. And what the health department does is when we're notified that someone tests positive for measles or we get involved, we will interview that case and we will do the best we can to figure out where they've been, whether they go to daycare, school, work. That's our part of our job, is to investigate where have they been and then make recommendations. If we learn that that child has been in a daycare while they were infectious, we're going to call that daycare and let them know, so that they know you have a case at your daycare and here's what we need to work with you on, and we'll go through those steps. But there could be some people that are exposed that we don't even know about now. So that's kind of a hard one there. Let's see.
I will say that, when someone applies for a vaccine exemption, they do sign that they understand that they will potentially be out for 21 days if exposed and not vaccinated. But please always refer to the rules and regulations in regards to that. And you can find that on the internet. Google it.
And then I think a question, is there anything we can do to mitigate the potential measles in the air? And there's really not. Now, measles doesn't like heat, but I don't recommend that you run the heat, so hot that you're boiling the children, and your workers. But sunlight, it doesn't like sunlight necessarily, but once again, you don't need to keep kids sitting out in the sun all day long either. So really, it's not like some of your other viruses that you can just spray Lysol and hope it goes away. It really can hang on. It's pretty hardy. So you do need to, if you have a measles case, we will advise you, if they've been in a room, we will tell you to close off that room, leave it alone for 2 hours, then go in and do your normal cleaning procedures. So we would be walking you through that if that should happen. And is measles something that once you get, you never get again? Usually, yes. Usually, if you have measles, you're not going to get it again. So that is true.
I will say that presumptive evidence of immunity against measles does include having previously had measles, but you need to have documentation of that because there were so many things that, kind of looked like measles in earlier years before vaccination. So to really have presumptive evidence of immunity against measles, it needs to be lab documented disease or lab documented evidence of immunity.
And then we have a question, do we need a booster of the shot if it's been 40 plus years since we had the MMR shot?
So in regards to that, if you've had 2 doses of MMR vaccine, you are good to go. There is a group of individuals, I think it's between 1962 and 19...
I was going to say 67, but I could be wrong.
I know.
There is a few years where the virus was not a live virus. It was a killed virus. Very few people got that.
Yeah, it's the, okay, so adults who were born after 1957 and vaccinated prior to 1968, there was about 5% of the population that got the killed measles vaccine or, a measles vaccine of an unknown type. And so for those individuals, if you think you were vaccinated during that time, there's no harm in getting an additional dose of MMR vaccine.
And that's what I was going to say is if you can't remember if you've had one or someone said, I think I've had it, but I can't find my shot record. It's a live virus. So as long as they're not allergic to the virus, they're not, sick with a fever or they're not pregnant, they should be able to get another MMR vaccine and it will not hurt them. But of course they would want to talk to their provider about that. And then does the 21 days apply to children with only 1 dose of MMR? So Dr. Cassie, take that away.
Kiddos that have had 1 dose of MMR are good to continue their regular activities.
And I think we've talked about the families with vaccine waivers. So if they, if they have an exemption, like Dr. Lotrideau said, they should be aware on the bottom of their paper that they signed that they could be, recommended to stay out. But like I say, that we may make that recommendation, but it'll be up to your facility to enforce the attendance policy. And what ages, again, should a child have received all their MMR shots? Typically, children get their first MMR vaccine between 12 to 15 months of age. And then the second dose is usually between 4 to 6 years of age. But right now, with the outbreak going on in those counties that we mentioned, or not necessarily those counties, but Faulkner and those surrounding counties, the vaccine recommendations is that a child 6 to 11 months old in those counties that live there or travel there can go ahead and get their 0 dose of MMR, which means they get a dose, but it doesn't really count. So they still have to get 2 other doses. Or if you have a child that's over a year old and they've had their 1 MMR, if 28 days has passed, they can go ahead and get their second MMR. Now, those are recommendations. Those are not, hard, strict. They have to have those. Yes, any comment on Fist disease? How similar is it to measles? I was going to say, I've been writing down some notes to make sure there were some things we covered. And my number one thing is lots of things cause rashes. So one of the things we do here at the health department as we talk to physicians and providers is we really try to say, tell us how the illness started. Did it start with a very high fever? Did it progress to this? Then did the rash appear a couple of days later? Or if they say, well, the child came in with a runny nose and they had an ear infection, we gave them amoxicillin, and a couple of days later they broke out in a rash. That's very typical. We hear that a lot. There is Fifth disease. There is rhinovirus or there's several viruses out there that are causing rashes. So it's very important to really kind of look at the rash, how it's presented. Also, are there others that have been around that are sick, that have been diagnosed or tested? So yes, Dr. Cassie put in the comments, you know, fifth disease caused by parvovirus, and it looks kind of like the slap cheek. So they have the red cheeks, and it usually goes from the face down. Or the rash of measles usually goes from the face, it goes down. All right. Okay, are we allowed to pull immunization records of employees on WebIZ if employee gives us permission? You'll have to follow your policy. That's the best advice I can tell you on that. You'll have to see what your policy tells you. If you have questions, you can contact our WebIZ staff. Do the large air filters we received during COVID help minimize the exposures? Well, that's a good question.
It's a good question. I think that in regards to air exchange and air turnover, the more frequency of the air turnover, that decreases the amount of measles virus that is in the air. However, I cannot specifically comment on the HEPA filters. That would be something that you should probably talk with either the environmental health about. But I would still not feel super confident that even if you have those and you're running those, are they working properly?
Right.
You know, what's their status? I think that it would still be, up
And
to
there's so many air exchanges that have to happen for it to be considered a true negative air pressure room. And you have to have the correct HEPA filter. It has to be working right, and it has to have so many air exchanges. And I'm going to tell you, unless you have a negative pressure room in a clinic, it's probably not going to happen. So that's probably that. Let's see, what else did I want to put?
Kat, there was one question about if you have the measles already, if you've had it, can you get it again? Will you get it again? So I don't think we've addressed that. And then for the sake of my colleagues who have been so incredibly helpful, they have posted a lot of information in the chat box. We're going to post this on the website, guys. They put their information, but I know we have some other things to cover, so I want to help them move on with their day, but also get on with the other things. I can tell you guys have a lot of curiosity about this, and I'm really excited about it, and I really appreciate Kat for reaching out. But Kat, if you could answer that question about if you have had it,
yeah, if you've had measles before, you should not get it again. Usually, once you have measles, it's lifelong immunity.
Okay. And then there was one comment about excluding families who are unvaccinated. And again, those are policies at your level. You can always have more restrictive policies than the licensing regulations or the Department of Health regulations. So, but it's certainly something that you would have to make a decision about, and it would be your decision solely, not of the state agencies.
Well, thank you so much for having us. We appreciate it.
Yes, Kat,
and if there's anything we can do, you let us know.
Yeah, and Dr. Luttrell, thanks to you and Kat for being willing to come on and spend so much time on this very, very important topic. And we want to do everything we can to help prevent this from causing havoc on our facilities as well as harming our children. So thank you again so much. I'm going to go ahead and move us to Donna Kirkwood, and who's going to talk to us about ASQ, Ages and Stages Questionnaire Training. So.
Can you hear me, Tanya?
Yes.
Okay. I know Donna had reached out earlier and was saying that she was having a little bit of internet issues because the rain was moving through the part of the state where she's located. I see she's there though.
Donna, can you talk, or do we need to push this to next month's meeting? So if you're either muted or we can't hear you. All right, guys, I'm going to keep us moving just because we are really short on time. And then if Donna wants to, if she's able to come on right at the end, we'll let her do that. Jennifer's just going to do a little reminder about town hall meetings, which thanks to Russellville and Jacksonville, the first two, and then she's got the last three. So Jennifer.
Sure. This is just a reminder. Tomorrow we're going to be in Mountain Home from 10 to 12. Next week, we're going to be in Hamburg, and then May 21st, we'll be in Forest City. If you scan that QR code or click the hyperlink, you'll get the exact locations with the addresses so you'll know where to go. So hopefully, we'll get to see a lot of you guys in the field in the next coming weeks.
Thanks, Jennifer. Grab that QR code and join us in those remaining 3 cities if you can. We look forward to it. We've really enjoyed getting to interact and meet with providers in the first 2 communities. So we're looking forward to Mountain Home tomorrow and the other 2 next week and the following week. I think next up is Dawn, who's just we've had a lot of, I always get a little nervous around March, April, because of hot weather. So she's going to talk about that. I know Neandra has put her phone number in, but she's also just going to talk about, we've seen a lot of maltreatments coming through recently, and we know it gets towards the end of the year and people get a little more relaxed. So I wanted Dawn just to kind of chat about that for a second.
So I just wanted to talk about, is a provider counting? I cannot stress to you enough about counting your kids. And when I was a director, I asked one of my really good staff, I said, just on a day, how many times do you think you count your kids? Like, just give me an estimate. So she got her one of those little clickers, just to look. And it was about 75 times a day. So that is an easy thing you can do. You count them when they walk in the door. You count them when you walk out the door. You count them when you enter the playground. You count them when you exit the playground. If you have to go to lunch, any time that you have children traveling, you should count them as you're walking into the playground. And that is something that I think is easy. That's just an easy thing to do. But you will always, and I'm not saying you have to take a roll. I'm not saying check off your list and go, okay, is little John here? I'm saying, I know I got 15 kids in my class today, 1, 2, 3, 4, 5. And if you can do that, you will always keep count of your kids. We have at least once a month where someone has left a child on a playground, left a child in a classroom. And I keep thinking, how can that happen? Well, I know how it can happen. You're walking out the door and the child runs back. But if you're counting them as you go to the next entry and they're going into the playground or the classroom, you count them then, that is just an easy way to keep up with how many kids you have. So that is just, I wanted just to stress that and talk about the hot vehicle. If you can, right now we are doing active transportation. So we are looking at everyone who either transports their kids on a van or they transport them on a bus or whatever type of transportation they have. Part of your policy is that you walk to the back of that vehicle and you look. Anytime we have had a child that has been left on a van or a vehicle, it's because someone didn't walk to the back. And when I say walk to the back, you walk to the back and you look under the seats and you make sure. A child's body gets hotter 5 times faster than an adult's. And I also think about what a horrible thing to happen and what it would do to a child. So that is one of those things that I think is easy. I just think that there shouldn't be any room for a child being left on a vehicle if you always walk to the back. To the back, look under the seats and make sure. And then again, as you're walking back into that classroom, you should be counting 1, 2, 3 and how many kids are that you have and that you know are in your classroom. We took off the ELS in June. We will have a big ELS update for everybody. And we'll have a step-by-step guide for you. It's out now. So if you have your specialist that's reported on the website, you can reach out to them and they can show you how to do anything you need on the portal. And
Thanks, Dawn.
11:59, I'll stop there.
Okay. Thank you so much. Hey, Donna's mic isn't working, so I just want to put a little plug in for her. She wants to make sure that administrators know about ASQ, Ages and Stages questionnaire 3 training for administrators on the 15th of May and June 19th. And so she's put in the forms. You'll get a free kit and learning activities. So you can register at the link that she's dropped in the chat box, and you can learn more about that developmental screening on the link that's below. So please join Donna for that training on May 15th and June 19th. And then last but not least, our own Paige Cox is going to make sure that you have information about our professional development for the upcoming year.
So, and nothing like being here right at the very last minute. So this is so important, guys. We offer free professional development through the Office of Early Childhood, professional development, training, technical assistance. So we've developed a new guidebook that provides a brief overview of the professional development. It contains the contact information, websites. As you're planning your professional development, you're looking at your needs, your staffing needs. We hope that you'll utilize this resource. Click on the QR code. The link is actually on the OEC website. I will drop it in the chat right now. And if there's anything I can do to help you, you can always reach out to me as well. So look forward to seeing you in trainings.
Thank you, Paige.
Go
ahead.
Also, I was going to say, so on the OEC website, we've made some changes. There is now a link called Quality and Professional Development. When you click on that link, it will include a link to the OEC class website. And I believe either Lori Bridges or Alicia Atwood's going to talk briefly about that.
Thank you, Paige. And yes, we are trying to consolidate and put all of the professional learning services that OEC offers into one location on the OEC website. So thank you, Paige, and your team for doing that. But we also wanted to share some class opportunities for our programs that have directors that are seeking certification in the class tool. So on that web page, you can see over on the left side, there is also scheduled class trainings. We do recommend that you work through your local lead with those class trainings as well, not only for observers, but they have some opportunities for your educators with some professional development as well. And then we also wanted to share the next slide on the summer letters for early childhood professional development opportunity. Last year, we were very successful with offering a summer session. The Bridge to Practice activities are touch points that go through the fall. We have to do that because a lot of our programs may not have children during those summer sessions for the Bridge to Practice. So again, you can go to this QR code or to the webpage, the OEC webpage that gives you more information about the opportunity around foundational literacy for the children we serve.
Thanks, Lori. Thanks, team. I know we went just a little over, so we're just going to wrap it up here. Our next meeting is June 3rd at noon, so that'll be our June meeting. I want to wish each of you a happy Mother's Day to all the mothers out there. If you're taking care of children, you're a mom, so happy Mother's Day, and I hope it's a really special day for you. Keep up the great work that we're doing here in our state, and thank you so much for taking care of children. The call will be uploaded to the provider call on our website that we always place everything on. So if you're interested and didn't catch something or need to go back to it, we'll have it there as soon as we can get it posted so that you can find out all this information, and especially the measles. Just keep it safe out there, guys. And if you have questions, let us know. But thanks for a great May meeting, and thanks for hanging with us for a little bit longer than normal today. We appreciate you. See you next time.